Hello, EGP learners. Today, Gandhi and I will be discussing a report from the UK Health and Security Agency looking at the effect on health inequalities and deprivation on rates of communicable disease. This is a really, really interesting report and really helpful for those of us out there who need to make a case for fairer funding and for the impacts that health inequalities have on the health of our population. So without further ado, let's take enhance your primary care and learning.
Hello, GP learners, and welcome to this episode. Myself and Andy are going to be talking about an interesting report by the UK Health
Security Agency.
Security Agency, yeah. So basically, public health department in terms of how infections impact attendance and what that potentially means in terms of resources within healthcare and what this may look like in your local area. How are you doing there, Andy?
Yeah, I'm doing pretty well. Looking forward to this sort of single story episode, going a little bit deeper and taking a look at the actual report behind the headline here. And as we said in the introduction, I think this will be really helpful for those people who need to go to their primary care network, their ICB, whoever they need to really to make the case for the impact that health inequality has, that caring for diverse populations have on services and the health of those individuals in those communities. So really, really interesting report.
Definitely. And I think this will lead into a lot of the discussions people may start to be having in terms of things like neighbourhood planning, in terms of their ICBs, in terms of where they're commissioning services moving forward, as some of that shifts away from NHS England directly and stuff. So definitely stuff to be mindful of, particularly if you work in an area of health inequality, which we're going to talk about right now, aren't we, Andy?
We are. So if we share the screen, so as ever, a lot of our stories start with Pulse, ever the friend of the podcast, nice free industry online newspaper. So they've sort of picked up on this report that's come out. The report itself, I think, was published on, in fact, let's just tick over to the report itself, updated 27th of May, but I think it was reported on early in May this year. There we go. The report came out on the 2nd of May, or the story at least. I guess, first of all, before we dive in, let's think about, so what is the UK Health Security Agency? So I think when I have the most contact with them is when I'm reporting reportable or notifiable diseases. That's, I guess, is that when you find that you're having the most interaction with them doing their online form? For that
Pretty
purpose.
much. And that obviously may now be increasing now that chickenpox has been added to that particular list that a lot of people may or may not be aware of. So since April, you are now meant to report chickenpox infections as well. But yeah, definitely the main contact I've had with them.
Yeah, and I think there were some interesting requirements for handling cases of chickenpox. I think we were having a discussion in practice about needing to wear FFP3 masks when assessing cases of chickenpox, which apparently is a requirement. I've not read the relevant paperwork myself, but our practice manager, who is also a clinician, had, and we were having discussions about how practical that was, and whether our pharmacy colleagues will be doing the same when they're assessing people with chickenpox and so forth. But I guess we're starting to digress a little bit, but those are the sorts of things that we're used to the UK Health Security Agency dealing with. So apparently this is the first time that they've set out the stark effect that health inequalities have on people's health, and in particular communicable diseases, because that's largely what they deal with at the Health Security Agency. So this is a bit of a first for them, making that link between deprivation and inequalities and difficult to doctor populations and communicable diseases. The UK Health Security Agency describes on its website its own function as the UK Health Security Agency prevents, prepares for, and responds to infectious diseases and environmental hazards to keep all our communities safe, save lives, and protect livelihoods. We provide scientific and operational leadership, working with local and national and international partners to protect the public's health and build the nation's health security capability. So that's what they describe as their focus. And this report in particular, so what is it doing? So saying this report aims to provide a high level description of the current state of inequalities in health protection in England. And they're focusing on 3 dimensions of health inequality here. So they're focusing on people living with deprivation, and we'll have a look at some of the graphs within the report in a few minutes. They're also focusing on people from different ethnic groups. And then they're also breaking it down by geographical inequalities. And a lot of the differences, as you might expect, come from people living in more deprived parts of Northern England and more affluent parts of Southern England. Although not all places in Southern England are affluent, and not all places
Nope.
in the north are
True.
deprived, but generally speaking, that's a pattern that we see. They also make the link to the Core 20 Plus framework as well, in terms of these populations aligned with the approach taken in the Core 20 Plus there. Although the Core 20 Plus largely deals with non-communicable diseases, effectively. So this is a different dimension of health inequality that they're looking at. So yeah, you with us so far, Gandhi?
Yeah. So I think let's have a look at some of the more detail that we've got within the report as well, shall we?
Yeah, well, actually, might be worth just looking at some of the headlines in the Pulse story, and then looking at where some of those headlines came from. So, just some of the headlines that Pulse picked out were that double the rate of an emergency admissions for infectious diseases in the 5th most deprived areas of England, compared to the highest quintile of affluence, and that cost the NHS up to 1.5 billion a year. That difference. So, if we could reduce the rates of communicable diseases in those most deprived areas to those in the least deprived, that would save 1.5 billion a year, which is probably about it's about 1% of the. It sounds small, doesn't it? Actually, is that about 1% of the NHS?
It is
budget?
1% of roughly the 1% of the NHS budget in total. Which you're right. That sounds like a small amount, but it's a huge amount of money.
It's a small percentage, isn't it? But it's a huge amount. I just had to check myself there, because 1.5 billion is a huge amount of money, and you can do a lot with that, despite it being, just in air commas 1%.
I mean, that's more than 10% of the primary care budget for general practice. So in terms of 10% of the care that's offered by general practice, that's huge.
Yeah, absolutely. And then they also pick up on geographical differences. So those living in the Northwest are 30% more likely to be hospitalized for an infectious disease compared with England overall, and 50% more likely to be hospitalized with an infectious disease compared to those in the Southeast of England, which is pretty. Yeah, I mean, that's huge, isn't it? That's
huge.
really, that's a really big difference. Just have to pause and appreciate that. And then it also talks about health inclusion groups. So people seeking asylum, people in prison, people experiencing homelessness, people who inject drugs are disproportionately impacted by a whole range of infectious diseases. And then finally, they say, sort of going forward, our data analysis of the evidence will help us and our partners apply a health equity lens to all our health security work to inform how we better target effective health services and wider interventions to those that most need it. So they're talking about targeting, I guess, prevention and and interventions where it's needed within the remit of infectious diseases. But you can see how a lot of this data is useful for making the case for all sorts of fairer funding decisions. So that's what I'd like to draw people's attention to.
Okay.
So shall we start to have a look at the report itself? So we'll put the link in the show notes, obviously. And as ever, often the best thing to do with these reports is read the executive summary. Have a look at the contents, which in the web interface is down the left-hand side here. And actually, probably on the first reading, scroll through and have a look at some of the graphs, because the most important points that they want to make and the most important data, they tend to break out in graphs. So I've got us a few graphs to have a look at in the show notes. Let's just scroll down and get to those graphs. There we go. So let's talk about this one. So figure 1, emergency admission rates from infectious diseases and infections by deprivation quintile in England. And it's over the year 2023 to 2024. So it's really recent data. And for those of you who can see the graph, along the x-axis, we've got deprivation quintile, with 1 being the most deprived quintile. This is using it IMD, so indices of multiple deprivation. It says 2019 there, so maybe that's the populations as defined in 2019, but it's 2023 data. I suspect that's what they mean. And then they've got admissions per 100,000 on the left-hand side, and helpfully they break it out by colour based on the types of communicable diseases that people are being admitted with, which is really interesting to have a look at. So I mean, I guess you're having a look at this data potentially for one of the first times. Gandhi, what's jumping out at you here?
So clearly the difference between group 1 and group 5 massively stark, first of all. So, group 1 being those quite deprived patients and populations and stuff versus group 5, more affluent, resource heavier patients, but also the fact the majority of those infections are respiratory based in terms of across the board. Most of those groups, at least 50% are respiratory infections. So that would be things like your upper respiratory tract infections, your pneumonias, COVID, I'm assuming is a good chunk of that as well. That still is around and evident, and obviously all the other pneumonia type infections that affect people. And then it reduces down from there to the various different things, with gastrointestinal pretty much being equivocal across the board, interestingly.
Yeah, that's
Looking at
something
that
I
one.
was noting here, that like the biggest difference is probably in the respiratory illness, isn't it?
Yeah.
With other infection, which I guess will incorporate all sorts of things. I'm not saying kind of urosepsis sort of broken out separately. So
Yeah, so
maybe
your
that's in your,
UTIs, your cellulitises, those kind of things, I'm guessing they're part of the other infection group and stuff.
yeah. So quite a big difference there with the other amounts. Oh, sorry, with the other conditions, yes, increasing as you go down in terms of deprivation, or up in terms of levels of deprivation, but with the bigger differences in those two
Mm-hmm.
categories. So just it's really interesting, and one can speculate about what's behind that, in terms of people's ability to access healthcare, how people are able to monitor and manage their long-term
Mm-hmm.
conditions, such as their COPD and so forth. But the difference is really, really stark here. Um,
I guess the other one to put into play, if we talk about health inequality, will probably be things like housing. So, those in the lower deprivation quintiles are more likely to be living in crowded housing, housing that may not be as effective in terms of, infection management space, etc., and that kind of stuff, compared to those who live in, quintile 5, generally less crowded environments, bigger rooms, for example, more resources to look after themselves, self-care, etc., and that kind of stuff, or other treatments. So, I wonder if that is part of the mitigating factors that come into play.
yeah, ability to have job flexibility, to seek
Mm-hmm.
help in a timely fashion, for example. You're right. I'm glad you've paused to make that point, Gandhi, because I think I'd started to make the same error many people do, in terms of thinking actually the main thing that will be driving this is people's access to healthcare, and what we know is that actually, in very general terms, in terms of people's health outcomes, 80% of people's health outcomes isn't to do with their access to healthcare
Yeah.
at all. It's to do with the other drivers of health, such as the things you've mentioned:
Mm-hmm.
employment, education, access to green space, good food, clean air. All of these things are really important and tend to be in more abundance with people with less deprivation. So it's not just about the healthcare. So let's keep going. So that's a good kind of deprivation lens in terms of inequalities. Figure 2 has some interesting data in. Might need to zoom out to see the whole of figure 2 here. That's probably sufficient. So this is the so inequalities in emergency hospital admissions between the most deprived and the least deprived quintiles in England, and it's a similar data that's used previously. So this is the difference in
Mm-hmm.
your likelihood of being admitted. So you're twice as likely with respiratory disease, for example, 1.4 times for other communicable diseases, 6.9 times more likely to be admitted with tuberculosis and measles, 6.2, for
Mm-hmm.
example. So this is another way of looking at that data, and sort of breaking out specific infections there. So it's the rate ratio, so compared to the least deprived quintile. So, and I think this is, I guess, showing similar data to the previous graph, but by individual categories. Measles is really interesting, isn't it?
Mm. An
And
unfortunate condition that we are seeing on the increase as well, very much so. So
yeah,
likely to be an impact in the next few years.
and largely preventable because
Yeah.
there are effective vaccines available, provided you have the appropriate proportion of the population vaccinated
Covered.
within your community, within your neighbourhood, to achieve herd immunity. And we've been kind of dipping below those levels in many communities in the last few years, and that's probably what we are seeing here. But just a really interesting and different way of representing that data. So they said another lens that they were looking at communicable diseases through was ethnic diversity as
Hmm.
well. So there's some interesting data there. And again, if you've got quite an ethnically diverse population at your practice, in your primary care network, in your neighbourhood team, as we might be discussing more in the future, this data is really, really useful in terms of planning what your
Hmm.
population might need, and also making that case for appropriate funding or appropriate contracting from your ICB. Let's zoom in a little bit more. So this is looking at the same colours for the different types of diseases: respiratory, other infection, other communicable diseases, invasive infections, gastroenteritis, contact, bloodborne and sexually transmitted
Hmm.
infections. And it's looking at the rates by different ethnic groups. So I guess probably the most abundant group is going to be your white British, which is sort of in the middle actually. So some populations having less less experience of
Hmm.
communicable diseases compared to the white British population. Below them in terms of experience are Indian populations, mixed white and black Afro-Caribbeans, black African. So it's quite interesting, isn't it, sometimes to see the effect
Hmm.
with mixed white and Asian and Chinese having lower rates of infection and communicable diseases, and then sort of up at the top in terms of having more experience of or higher rates of communicable diseases. You have black other populations, white other, mixed other, Pakistani, Asian other, and so forth there. So it's just really interesting, and actually taking the admissions per 100,000. In the Chinese population, the least affected, it's less than 2,000, and then we have
Hmm.
getting on to nearly 7,000, so over 3 times the rate in the black other population. So just
Yeah, I mean, just looking at that simple data, so the populations where Chinese of origin in total admissions base is less than the black other category just for their respiratory admissions, and I think even just for their other infections category as well. So it
yeah, I mean it
shows
all
the stark difference, doesn't
yeah,
it?
yeah, it all fits within respiratory or within other, as you say. So really, really interesting. And I'm sure people are looking into why that is. There might be all sorts of lessons there, that those
Mhm.
lessons may have already been learnt, but it's just really interesting looking at
Mm.
that data. And this is another tool that you can have for talking about the health within your
You never know.
populations.
There's something in there about a risk calculator based on ethnicity that impacts the likelihood of admission from an infection.
Yes, yeah, I'm sure people are working on that.
Mhm.
Yeah. So interesting. And then I guess another table, which is one to have a look at the report and dig into. But again, this is interesting and goes into even more detail based on ethnic minority groups and admissions. So this table it's the inequalities between ethnic minority groups and white British groups in emergency hospital admissions. So this is taking your so I think as so one, so it's a rate ratio taking the base case as white British,
Mhm.
and then if you have a higher figure, then you're more that group is more likely to have an admission. If you have a lower figure, which they do for a number of conditions, then you're less likely to be admitted with that condition. So if we look sort of right at the top in terms of tuberculosis admissions, black other category, 41 times more likely than white British to be admitted with tuberculosis. And actually, tuberculosis accounting for many of those really high relative
Mhm.
levels of admission compared to white British population. And then for just at the other end of the spectrum, for some conditions, so let's have a look at let's just take soft tissue and skin infections. 0.7 risk for mixed white and Asian. So just interesting to have
Mhm.
a look at. And if you're doing specific work around these, specific infections in your primary care network, your practice, your work, then this data may be really, really useful
Mm.
for you. So just with bringing people's attention to it. And then the final lens, because we said there were three lenses, so inequality, ethnic groups, and geographical distribution. So there's a number of graphs looking at geographical distribution. Let's zoom out to have a look at this. But this looks at the number of admissions per 100,000 in the different regions of the United Kingdom. So those of you who can see the graph, you have what I think are the main NHS regions with
Mhm.
the thick purple outline. And then you have, I think these are individual ICBs within there, the individual shaded areas. The darker they are, the higher the rate of admissions per 100,000. So, geography test, Gandhi, can you spot Nottinghamshire on there?
I think we are that middle bluish one. Yeah, that's the one.
Yeah, that's us, isn't it? I think because Derbyshire and Nottinghamshire look a bit like the thyroid gland if you
Mhm.
put them together, because we've got a combined authority now, haven't we? We've got a combined mayoral authority, and I think it's sort
Mhm.
of in the logo, this thyroid-looking shape,
That's one way of thinking about it, Andy. Yeah, that's for sure. But
butterfly.
the key difference you can see is that there's a much denser, darker graph towards the north of the country compared to a much paler, lighter one towards the south of the country on a general thread. Apart from that one dark blue bit in the middle, which I can't quite figure out where that is.
Where is I was just trying to think where that is as well. It looks like it's in the Midlands, isn't it?
Yeah,
Are you bringing up a map separately,
I'm
Gandhi? I
having a
saw
quick
you
look.
onto your keyboard.
So it's below Nottingham. We know that for
It's
sure.
below Leicestershire, isn't it? Is it Northamptonshire?
I believe it might be. Yeah, Northamptonshire. It'd probably be the
Yeah.
yeah.
I wouldn't have pegged them as being super deprived, but I guess
So
what
one
do I
below
know?
Nottingham will be Leicestershire. So there,
Yeah.
that would be Northamptonshire.
Yeah. Okay. Well, what do I know about Northamptonshire? But there we
Mm.
go. They got rates similar to the north and northeast. So, so so interesting. And obviously, the report, breaks out this information in a lot more detail. And as ever, the purpose of these videos is really to let you know kind of what's in these reports, draw your
Mhm.
attention to them, reduce that barrier for entry for people to pick up and have a look at these reports. So there we go. So report from the UK Health Security Agency looking at the effects of those three lenses of inequality, ethnic diversity, and geographical distribution on infectious diseases, which is their main purview. Um, so quite interesting, really. And they've
Mhm.
told us that they will be using this information in the content of the report to inform their strategies to address
And I
communicable
think
diseases and also what do they say? Environmental hazard as well.
true.
So that's air pollution, work-related issues, things like that as well.
And I think for us in primary care, the key way to look at this is particularly with this increasing discussion around neighbourhood-based working, INTs, all that kind of stuff. This is information that's potentially quite useful for you to be aware of and share and impact with in terms of how you adjust the rate of services. I guess there's the capacity and access improvement plan. There's going to be this risk stratification part of the module that looks at some of this that may give you a little bit more information on where to focus some of the services needs and stuff. We're still waiting the detail on that, obviously, in terms of what the specific aspect of that is. But this information that may help to contribute to the fact that particularly areas of deprivation, high inequalities and stuff and things may be where you need to look at some of those key focuses to adjust how you respond to those different impacts. That's why I'd be thinking looking at that, Andy. What about
Yeah,
you?
definitely. Yeah, the other thing that strikes me is that a lot of the work that we've seen or that we've discussed so far looks at non-communicable diseases.
Mhm.
The six disease strategy that we saw last year from NHS England, Core 20 plus 5. Largely these are non-communicable diseases, which obviously are responsible for large numbers of admissions. But it's just interesting to see the communicable disease lens, and that's an
Mm.
area where we might think, oh, this is more down to chance, contracting
Yeah.
communicable diseases. But no, this is really affected by people's circumstances, ethnicity, income levels, and where they live in the country.
Mhm.
as well. So, and there are lots of admissions and unexpected deaths attributable to these
Yep.
diseases, particularly sepsis. So it's really important piece of work, I think. How do you think what impact do you think this might have going forwards, Gandhi, or any further thoughts?
Well, I think there's some useful information in there, like I said. So, if you happen to have a practice population that was high in other Black patients and stuff, particularly in terms of tuberculosis-based patients, that'll be something to look at. You've got some real quick wins potentially to have a look at in terms of what there is. I think using some of that ethnicity data to help direct in terms of infection control aspects for your local population may be useful, and also thinking about how does that data inform those, like I say, service-based decisions in terms of access and stuff. There may be something in there about looking at that, and like I say, working with your INT partners to understand how that can be changed to impact admissions base and risk assessment base in those patients as well.
Yeah, absolutely. And I guess the way I'd be thinking about it is in terms of levels. So, as a GP or health professional, thinking about the patient in front of you,
Mhm.
actually, where are you practicing in the country? What are the characteristics of the patient in front of you? And does that mean that you might need to be more sensitive to the potential need
Yeah.
for admission or deterioration to the point where they might need to be admitted based on income level, ethnicity, things like that. At practice level, it's about planning services, similar at primary care network level. And then at ICB level, I think there are questions to be asked about funding allocation,
Mhm.
both in terms of the ask for funding allocation and perhaps also the explanation of variation in outcomes between practices. If you're a practice in an area experiencing many of these challenges and your outcomes are not necessarily the same as practices not facing these challenges, well, this might be the reason why it might not be your performance as a practice. So, and sometimes these things need to be raised with the ICB as well when these things are being looked at. So, I guess those are the sorts of lenses, and I'm sure Department of Health, NHS England, will be aware of this as they plan
Mhm.
the next GP contract. As that's being negotiated,
Maybe.
as the BMA negotiate it, maybe they need, to be aware of this as well. I'm sure there'll be some discussions about fairer funding in those contract negotiations. But hopefully that was interesting, Gandhi.
Yeah.
Hopefully everyone out there found it interesting. And
Definitely. And if you want to check out more information, do check out our earlier episode that we covered last week that talked about the DDRB impacts of how that's going to work for general practice and various other news stories, particularly around capita and other aspects. If you want to check that and content out, have a look right here because that's probably coming up right for you right now. And as ever, we'll be here to tech and answer your primary care and learning. We'll catch you in the next episode. Bye.